Clinical features and management of hypocalcemia. Clinical features. Hypocalcemia refers to a lower than normal serum calcium concentration, typically defined as total serum calcium 8.5 milligrams per deciliters or ionized calcium 1.1 millimole per milliliters. Symptoms and signs of hypocalcemia result from increased neuromuscular excitability and may vary depending on the severity and duration of hypocalcemia. 1. Neuromuscular symptoms. Paresthesias, tingling or numbness, commonly in the fingers, toes, and around the mouth. Muscle cramps, spasms in the hands, feet, and face. Tetany, severe muscle spasms, hallmark of significant hypocalcemia. Chvostek's sign, tapping over the facial nerve induces facial twitching. Trosso's sign, inflating a blood pressure cuff above systolic pressure for 3 minutes induces carpal spasm. Seizures, generalized or focal seizures, especially in severe cases, laryngospasm or bronchospasm, life-threatening complications of hypocalcemia. 2. Cardiovascular symptoms, prolonged QT interval, visible on electrocardiography, ECG, may predispose to arrhythmias. Hypotension, reduced myocardial contractility in severe cases. Heart failure, rare but possible in extreme hypocalcemia. 3. CNS symptoms, irritability, depression or anxiety, confusion or cognitive impairment, fatigue or lethargy. 4. Chronic hypocalcemia features, cataracts, abnormal dental development, basal ganglia calcifications, which may lead to movement disorders, e.g. Parkinsonism, dry skin and brittle nails. 5. Causes of hypocalcemia, vitamin D deficiency, common worldwide due to inadequate sun exposure or poor dietary intake. Hypoparathyroidism, post-surgical, autoimmune, or genetic causes. Chronic kidney disease, CKD, impaired calcium and phosphorus metabolism. Magnesium deficiency impairs PTH secretion and action. Acute pancreatitis, calcium deposition in necrotic fat. Medications, bisphosphonates, loop diuretics, or phenytoin. Critical illness, sepsis or burns. NASH, management. Management involves treating the underlying cause and correcting calcium levels to alleviate symptoms and prevent complications. 1. Acute severe hypocalcemia, symptomatic. Indications, tetany, seizures, laryngospasm, prolonged QT interval. Calcium replacement, intravenous calcium, calcium gluconate, 10% solution, 10 to 20 milliliters diluted in 50-100 milliliters of 5% dextrose or normal saline, infused over 10 to 20 minutes. Continuous infusion, 0.5 to 2 milligrams per kilograms per hour calcium gluconate for ongoing severe hypocalcemia. Monitor, cardiac monitoring, ECG, to avoid arrhythmias due to rapid infusion. 2. Chronic hypocalcemia, oral calcium supplements, calcium carbonate or calcium citrate, 1 to 2 grams of elemental calcium per day in divided doses. Vitamin D supplementation, ergocalciferol or cholecalciferol for vitamin D deficiency. Active vitamin D analogs, calcitriol, in cases of hypoparathyroidism or CKD. Magnesium correction, address hypomagnesemia if present, IV magnesium sulfate or oral magnesium salts. Thiazide diuretics may reduce urinary calcium loss in hypoparathyroidism. 3. Specific treatment based on cause, hypoparathyroidism, lifelong calcium and active vitamin D supplementation. Vitamin D deficiency, 50,000 IU weekly ergocalciferol or daily cholecalciferol until deficiency resolves. CKD, control hyperphosphatemia with phosphate binders and provide active vitamin D analogs. 4. Adjunctive care, regular monitoring of serum calcium, phosphorus, magnesium, and PTH levels. Dietary calcium intake recommendations, e.g. dairy products, fortified foods. Avoid excessive phosphorus intake, e.g. soft drinks in CKD. Complications to monitor, recurrent tetany or seizures, cardiac arrhythmias, e.g. ventricular fibrillation, permanent cognitive impairment if hypocalcemia persists untreated. Management of hypocalcemia is a multidisciplinary effort, often involving endocrinologists, nephrologists, and dietitians, especially in chronic or complex cases.